Call this meeting back to order from yesterday. Welcome to the regular session of the Board of County Commissioners. It's Wednesday, April 23rd, 2025. Today we finish up our business for the county with a work session with our Health and Human Services Director, Eve Gray, and her staff concerning the presentation of current financials of the community health centers of Lane County. Perhaps maybe a difficult topic, but we're glad you're here this morning, so take it away. You have all the time you need.
Thank you. We'll try not to take all morning, but I can introduce my team first. So Zach Evans, I think most of you know most of the members of the team. So Zach Evans, Assistant Director for Administration and Finance. Suzanne Roloff, our Chief Operating Officer / Division Manager for the Community Health Center Clinics. Lisa Willis, who is our HRSA Designated Chief Executive Officer for our Federally Qualified Health Center, and also an Assistant Director in Health and Human Services. And sitting right there momentarily will be Noelle Moran, who is our Division Manager for Clinical Financial Services. So what my job is today, I think, is to set context, and then, as always, I will pepper in because I can't stay silent. That's a trait of mine. The context that we are, if we think back to last year, where we were in terms of our community and the health system in our community, we had a notification from Peace Health that Eugene's Only Hospital was closing. And a lot of concerns from Eugene residents around access to health care. As well as calls to us to do things like build a hospital, right? Which is outside the scope of what we are able to do. But then folks saying, if not that, what are you going to do in order to assure access to care in Eugene and care for immediate needs, not just an appointment that might be available months out? Combined with that, we had an Optum acquisition of Oregon Medical Group, which resulted in many, many primary care providers choosing to seek employment elsewhere. And the options were provide a landing place for folks who are interested in continuing to stay in our community, or all of those primary care physicians, of which I believe in total the physicians lost was more than 30 at Oregon Medical Group, not all of them in primary care. So we couldn't land the specialists, that's not what we do. But if we didn't provide places for those who wish to stay in our community, all of those primary care providers were going to leave our community and make access even worse than it already is. And all of us know that access is not good. Now, all of this happened at a really bad time for us because we also had recognized shortly after I started with Health and Human Services that our electronic medical record that we were using, NextGen, no longer met federal requirements for meaningful use, and they were not intending to upgrade the system to be able to do that. That puts millions at risk for us. We are required to meet meaningful use. At the time, we happened to have some ARPA dollars that were going to expire that we decided to put toward a new electronic health record. This is the context. The opportunities that came available to us were multifold. All of them, we knew, lead to a deficit in healthcare. So we were presented with an opportunity to open an immediate access clinic in Eugene in order to meet not the emergent needs, but urgent needs of members of our community who are the population that was frequenting University District sometimes 100, 200 times a year to the emergency department. That's the population that we as an FQHC should be set up to be able to serve. And so, but we needed the immediate access in order to do that. Peace Health offered us their West 11th clinic right there at Fred Meyer on West 11th in order to provide immediate access care. We also had a number of Oregon Now, when you open a new clinic, you run at a loss. Why is that? It's because you bring on all the expenses and it takes time to build up the patient population that brings on the revenue. Same thing we had nearly 10 providers knock on our door. from Oregon Medical Group or other providers in the community saying, I'm unhappy where I am. I'd like to stay in Eugene Springfield area. Do you have a spot for me? And of course, we were opening a new clinic. We had a lot of locums providers or very expensive temporary providers. And we normally, when you hire providers, you hire them one and then you wait a little bit and then another one and then you wait a little bit. Why is that? It's because you take on all the expense and they don't yet have a full panel of patients. We were inundated with providers where we had to make a choice. Are we going to offer a position for these folks or are we going to lose them in Eugene Springfield? And we made the choice right there in that context to hire these providers, which we knew was going to put us into a financial deficit. Electronic health record transitions also are very, very difficult. There is always revenue lost when you are transitioning from one health record to another. It's a part of the process, and there's a lot of financial monitoring that goes into that transition, but it is a time of great financial risk. And it was something that we couldn't delay because of both the meaningful use requirements and the ARPA dollars expiring. And so we had these three things that we knew were going to put us in a deficit situation. And then there were other things that happened that the team will talk to you about that we didn't expect that put us in a greater deficit than we anticipated. The good news, spoiler alert, is that we're working really hard to correct that, and we have projections that say we should be able to do that next year. However, we also didn't anticipate all of the rapid changes at the federal level, and we still don't know what the ultimate impact will be. So our projections are as good as what we know today, and should there be significant federal reductions that impact our revenue streams, it will dramatically impact our ability to close this gap. And so we felt it necessary, given the deficit that we're running right now. Some of it is based on one-time spending that we don't anticipate going into next year. Some of it is based on this operational ramp up in new clinics, new providers that, again, we expect to correct next year. But there is that risk that if we lose too much on the federal side, it will be very, very difficult for us to recover this. So that's the context and why we wanted to bring this conversation to you right now so that you're not in the dark and you can ask all the questions that you have today about where we are and where we're going. So with that, I will turn it over to the team and they'll do the bulk of the presentation. Thank you.
Just a reminder going forward, I don't mean this to be rude, we're talking to the public, so let's try to refrain from using a lot of acronyms that everyone in the room knows, but perhaps the public might not.
Got it.
Thank you.
So, good morning, everybody. One of the things she did not mention is over the last year, the CHC was celebrating their 20th anniversary. So we have been in business for 20 years, serving the community. Had quite a number of internal events and some recognition events for our different clinics as we celebrated those 20 years. So it's kind of a neat milestone in a year of tremendous, tremendous change. Our vision and our mission, improving the health and wellness of our community through access to affordable and holistic health care. That is the mantra of a federally qualified health center, or an FQHC. That is what we are tasked to do from the federal government. That is our reason for being, is to provide access to affordable health care. So, in a federally qualified health center, the focus is mainly on primary care. So mostly physician, primary care services, pediatric services. We have some additional services within our clinics, our dental outreach and prevention programs, as well as our community health workers is a new initiative over the last couple of years. There's been quite a focus on having community health workers. I'll talk a little more about that. We have a great pharmacy support team that helps support patients access low-cost medications, as that can be a real barrier to their health care through the 340B program. We have pharmacists that work directly with our patients to help them understand the medications and get past any barriers to taking their medications. Often we'll have things along the lines of a patient may not have electricity where they are housed, and so they can't have a medication that needs a refrigerator. And so our pharmacy team will work with the patient to find alternatives or find other ways to help them access their medications. We have limited specialties, and we'll talk a little bit about that as well. We do have an allergist who comes in. Allergy, obviously, in the Willamette Valley is a high need service line, and a lot of our community partners don't take Medicaid. And in doing so, we provide an allergist a day a week. That's an important specialty we feel for our patients, as well as developmental pediatrics. That's a specialist who works with us periodically. Sorry. Okay.
Thank you, AI.
Must have talked to my watch. Our developmental pediatrics helps us with things such as ADHD evaluations, autism evaluations, and other services that are really hard to reach in the community, again, for the Medicaid population. Our dental care program, I'm going to just go back to that one because that's such a biggie for us. That's why I saved it to the end. Our dental program is tremendous. We have an outreach team that you probably are aware of that goes to every elementary school in Lane County, across the entire county, servicing kids in the schools to do screenings to ensure that they have access to at least a screening exam for their dental needs, finding all sorts of potential dental issues. It can be really hard sometimes to get them connected to services, but our dental team does that as well. And then our prevention program inside of our clinics, we had 2, now we have 3. We have added our integrated oral health to our South Lane clinic, and those are services for patients who are coming in that maybe also have never seen a dentist or don't have a dental screening. We're able to do that screening for them. Dental health is physical health and can impact it so greatly that getting patients connected to resources related to their dental health is really, really important. Okay, now next slide. As Eve mentioned, of course, the West 11th Rapid Access, opening a clinic in less than 6 months was pretty tremendous, I think, for a county initiative to happen, but we did open in July of last year. And to give you a sense of the volume, January through March, we've seen over 2,000 people in just those 3 months. That's with 2 providers. We do have one of our providers right now who's retiring, but we have a new one, another OMG, who is joining us in the fall. So we will still have 2.5 providers at West 11th.
Suzanne, can we interrupt just for a question? Are you okay with us questioning on the way? Okay, great. Go ahead.
Just quick, the 2,000 is 2,000 unique individuals or 2,000 visits?
2,000 patients served, so I would, it's
So
not
more
gonna
than
be-
2,000 visits? Because some of
no,
those patients came more than
yes.
once?
It's possible the patient
Potentially?
came in more than once,
Okay,
yeah.
and
Those are
same with
2,000.
South Lane. Okay, great, thank you, thank you.
But that's the other, the piece that happened last year is our South Lane Clinic, which of course has been in the works for 17 years, I think it is, right, Commissioner Buck? And we did finally open in late September of 2024. That has been a little bit of a slower ramp up, honestly. Staffing has been an issue. We knew that would potentially be a challenge. And it's not staffing of our providers. We have 3 really, really great providers, including one from the community who left their community practice and came to join us, bringing with them several of their patients. It's been the staffing support, the medical assistants, the LPNs. That has been a real challenge. And we're working collaboratively with LCC, who's located in that building. We went to a job fair just last week to try to help encourage folks to help us with our staffing levels there. That's directly impacting the number of patients that we're being able to serve and how fast we're able to ramp up our patients at South Lane, which is why that number is so much less than West 11th. January through March, 1,200 patient visits in those 3 months, so about 400 a month so far. It's increasing month over month as we would expect, but we'd like it to be higher than it is currently.
Suzanne, do you think that staffing issue is a location issue or just because we're not outputting as many people from colleges as we should?
It's both. So a rural clinic is always going to have a harder time staffing a unique specialty such as a medical assistant or a licensed practical nurse. And there is no medical assistant school. There used to be Pacific University used to have a program here where we were putting out, was it something 85 to 90 MAs a year? And now LCC has a program and their capacity is about 25 to 30. I remember the last time I looked, which was probably 15, 16 months ago, there were over 200 medical assistant opportunities in Eugene Springfield.
And LCC would grow their program if they had the applicants. The problem with the medical assisting program is you pay tuition to go into a profession that does not pay very well. And it is really difficult for them to recruit students. So they have indicated to us that they would grow if they have the demand. I think as we continue, we have tried to work through apprenticeship program with limited success. And we're recruiting folks into the program, and whether it's generationally or maturity wise, we're having to teach them things like why it's important to come to work on time, why it's important to be at work when you are scheduled. And that has made it difficult for us to have successful folks working through the program.
So I'll tap onto that. One of the initiatives we're looking at right now is there are other medical specialties that can do the job that helps with rooming, such as a phlebotomist can help out in quite a number of ways, as an EMT can also help out. So we're starting to look at that, and we may come back to you in 4 or 5 months with some ideas of additional classifications that may help support the work that we're trying to do. So I wanted to just share a couple of success stories because there have been hundreds of them, but just to really bring in line how important our presence has been in South Lane, this particular situation, patient was reclusive and had gotten so ill he was using washcloths taped to his back for his wounds. Must have gotten so sick that he did finally wind up going to the hospital. And then the hospital coordinated with us. We worked with Peace Health in Cottage Grove to help get services to the patient. We got him seen, got him connected to food because he indicated, at least when he was in the hospital, he was being fed. So we helped get him resources there and transportation to his specialist. And so he is now starting to re-engage in the community and follow up with his chronic conditions, which is really exciting. West 11th, again, I could probably give you a story every day from West 11th and how successful that clinic has been. And this is sort of our initial reason why. How do we help stop the hospitalizations? How do we help provide an access point so that patients don't go to the ER? And these two patients, within a couple of days of each other, had been discharged from the hospital, didn't have established PCP relationships. And one of the problems with that is if you don't have a primary care physician, which is PCP, you can't get a home health order signed. And so you're getting discharged from the hospital and you need home health care because of whatever you were seen for. And you don't have anybody that can sign that order. So home health care won't come. And in both of these instances, they saw us the day after discharge. We signed their home health care orders. They got the care that they needed, and they didn't have to go back to the hospital to have their wounds looked after. So again, exactly how we intended for this clinic to function is how it's functioning. And now they're established with us, and we're seeing them for their chronic care conditions.
So as Eve started with some information around some of the challenges that we've experienced over the last fiscal year, again mentioning the OCHIN Epic transition from NextGen, we definitely saw a decrease in productivity during the early implementation phase. We actually planned that would be the case as providers and staff are learning how to chart in a new system, how to navigate between the various screens and fields as they're caring for patients. So we actually planned that there would be lower productivity with a ramp-up period in those first 2 to 3 months using the system. We have experienced ongoing challenges having the system configured in a way that optimizes our work. And part of the reason we went with an established vendor, which is OCHIN, rather than purchasing Epic right out of the box, was so that we could adopt some of the best practices. They have extensive experience working with FQHCs within the Oregon market, so would be very familiar with our payer requirements, our reporting requirements. And so we had the benefit of that. The challenge is that it is not as flexible because we are part of a consortium. And so changes to the system are not based on a particular client's desire to use it differently. It actually has to go before an entire group of clients and users and be evaluated for broad implementation and build. And so we have found that there have been challenges adapting our workflows in order to work within the OCHIN system to the best of the system's capabilities.
Commissioner Barr, go ahead.
Thanks. And the reason we chose OCHIN was because, rather than out of the box, because of its flexibility. But then you described a relatively inflexible system.
Because
So-
we are using a third-party vendor for our instance of Epic. So Epic out of the box, you would build it from the ground up. OCHIN already has a skeletal build that is largely functional right at day one. And so rather than us configuring an entire electronic health record, this put us ahead of that game. It would have taken much longer to build and implement a
Thank
new
you.
electronic health record had we not used the vendor.
That gives the clarity. Thank you.
Great, thank
And
you.
OCHIN is specialized in FQHCs as well. So they have several federally qualified health centers across the country.
Yeah.
We were
and
the first. So,
some of the other-
not for them, but for the world.
Yes. So we have been working with OCHIN. You can see here some of the statistics around our ticketing volumes in terms of what we have to work back and forth with OCHIN, recognizing that our resources internally around our analysts that support the electronic health record are very limited, given a lean budget. And then working through the ticketing process with a very large organization has taken a lot of back and forth as they're learning about us as a client and we are learning their process. And so you see there are a number of things that historically we would have just taken care of internally that we now need to work through their process and that larger client list. We do have regular meetings. The revenue cycle team is meeting weekly. We have an executive sponsor touch point every 2 weeks now that we are in the maintenance phase of our implementation. And then we have ongoing monthly meetings with our clinical teams and OCHIN to continue to optimize our workflows and make sure that we're using the system at its best performance, which is where we will see long-term savings and improved healthcare and follow-up for our patients. In alignment with Eve's earlier comment, there have been some other challenges that have had a direct impact on our revenue cycle service. And those have been completely outside of our control and have been because of outside vendors that control the transmission of claims as well as payment information. So TriZetto is a clearinghouse. That is an organization that submits claims as well as receives electronic payment records back from the insurance plans. And we, as part of our enrollment with OCHIN, TriZetto is their preferred clearinghouse. We had challenges because any other instance of groups using the TriZetto clearinghouse under our Lane County tax ID disrupted previous users of that tax ID. So we experienced that in our juvenile justice area as they were looking to enroll with that clearinghouse, dislodged our previous enrollment with TriZetto, which took some time to navigate through and get that cleared up. We have now successfully navigated that so that both parties are able to use the clearinghouse and have added our Lane County Treatment Center program that is using an alternate electronic health record is now able to use TriZetto too. So we actually, as part of this work, created some real flags to the vendor in terms of improvements that they needed to do on their side to accommodate organizations that are doing this type of work in various settings and using different systems to transmit those claims. So overall, an improvement and should help us moving forward. We had a breach with one of the major clearinghouses on the payer side. So Change Healthcare had a security breach, which required that they shut down all electronic transactions. So we began receiving all of our payment files on paper and required manual posting. And you can imagine, as we're serving a population of over 30,000 patients in our community. That's a lot of hand posting for a very small billing team. So as a result, a lot of resources had to be devoted to the posting process so we could record those payments and appropriately follow up on any balances, which took us away from some of the claim follow-up and charge submission that those individuals would typically be doing while they are diverted to other tasks. And then our Medicare enrollment, we have to enroll both our facilities, so each of our clinics as well as each individual provider, and that is revalidated on a regular schedule by Medicare. And so those re-enrollment process can sometimes hang up your credentialed status as you're navigating the CMS system, getting those things updated. Their communication is not always very clear as to which clinic they're asking for or what it is, what additional information they need. So very often that takes an extensive period of time, and we've had a few hiccups in that process that have required additional attention.
And just a little bit of extra context around this. Some of this is recoverable, some of it isn't. So when we experience significant delays in our ability to submit claims, we ultimately lose some claims due to lack of timely filing. So that becomes revenue lost. Whereas the big batch of claims that we have held up because our clearinghouse won't let us submit, or because Change Healthcare is shut down and we can't communicate electronically or bill PacificSource, was massively impacted by the Change Healthcare breach and healthcare providers all across the country. So we can recoup a lot of the losses, which means delayed revenue and revenue that will be coming in, hopefully posting to this fiscal year to help us with our deficit for this year. But then there is a certain amount that we have to write off when things like this happen.
So my questions.
Okay, so in looking at the current challenges that we have today, as well as future plans and how those could be impacted based on the revenue occurrences that are happening over the last fiscal year, we have some challenges and opportunities. One of our opportunities is to go back to our payers that we currently have capitated arrangements with, which is a different payment model. We aren't paid per visit. We are paid per patient who we are caring for. And so PacificSource will assign those members to us as their primary care provider and will pay us once a month a flat rate to care for that patient over the course of the year that they are enrolled with that payer. So this is one of those things where if you have a patient that has acute needs and needs to be seen frequently, you will end up in a situation where you are paying within your health system a greater amount than what you are receiving in reimbursement from the payer that is intended to be offsite by some of their healthier members that require less services per year, and you are still receiving that monthly payment whether the patient walked through your doors that month or not. And so there is intended to be a balance if you have a proper mix of patients that are assigned to you. I will flag that as an FQHC, we are typically caring for the sickest amongst our community because they lack other social needs. They don't have those needs met, and so they tend to have greater health needs. And so we don't see necessarily the same distribution of patient needs as perhaps another organization would. So as a result, we need to be really meticulous about how we're presenting to our CCOs in terms of what we need to continue to run a sustainable practice.
Lisa, that sparked a couple of questions. Commissioner Farr, go ahead first.
Twice you mentioned PacificSource specifically. One time was with the Change breach, and the second time was we have difficulty, I think you said, billing PacificSource. Now, is that specific to PacificSource, or
It
Is
is
it both
not-
CCOs?
So the unexpected impacts from these external vendors was specific to Pacific
Okay.
Source just because of the vendor.
Because
It
of
is
the
not a reflection on the health plan
Right.
or difficulty working with that health plan.
But it was peculiar to one of the CCOs, not both. Okay.
And the CCOs are the community care organizations?
Correct,
Right, okay,
Trillium
thank
and
you.
Pacific
Right.
Source.
Yeah, Commissioner Truther, please.
Thank you. Who sets the capitated rate? Is that a negotiation between the CCO and us? Does the same one have to apply with both CCOs? Is there statute involved in that? What is that process and how frequently can it be renegotiated?
Yes, it is negotiated between the CCO and Lane County. The contracts typically have a 1-year duration, but have no end date specified. So you can reevaluate that annually. They do not have to be the same rate. It is based typically on your utilization, your cost of care, as well as the health plans per member per month from the state and what they can afford to pass on to the provider. In addition to that PMPM, per member per month is another way to refer to the capitation payment. There are some incentives offered by one payer for having additional supportive services in place and are not necessarily offered by the other payer. So you can run into a situation where there is a notable disparity between the compensation you get from one CCO versus the other. And that is one of the things that we are working towards reducing as we're approaching negotiation conversations with our CCOs.
So are they on the same schedule and is this aligned with our fiscal year for when the opportunity to renegotiate, if I'm understanding, you can only renegotiate once a year based on the contract, but the contract doesn't have an end date, right? So are they on the same schedule and does it align with our?
It is a
Fiscal year.
January to end of December
For both.
contract period.
Oh, it's a calendar year.
It is a calendar year
Okay.
for our CCOs.
So we're
They are set
actively
up to-
negotiating that still we're midway through the contract
Right.
year.
We are actively negotiating that. They have, we requested an analysis of our data so that they could come back with an offer. And we have received a response from Pacific Source that we cannot accept right off the bat, based on what we know our costs have increased over the years. We're still waiting for a response from Trillium. They are in a similar boat of uncertainty around Medicaid funding. So it's a challenging time for us to go back and say, our costs have increased and we need our reimbursement to reflect that, as they are also seeing their costs increase and their Medicaid funding at risk.
And can I ask one more, not to put us too far down a different maybe a different presentation and conversation, and also I just need to learn more about the structure, because it's been a while since the CCOs were stood up, but are our FQHCs their only avenue through which to support clients accessing care? In other words, right.
And
So
just a
please
little.
explain that question for the public, because they probably didn't know what you just asked. Are you saying that the
I'm
federal-
saying that I understand that they're facing some of the same constraints and potential threats that we are to the ability to provide services to the community because of federal changes around potential federal changes. But those changes will impact them differently than they will impact. I was going to say, without us, they can't deliver on their mission, but that's not necessarily true because they have other avenues through which to reimburse for care.
Right, and if they see eligibility changes that reduce the members of our community that can receive Medicaid benefits, they will not have the volumes that they have today, which we are essential in serving the volume of members that they support. Were that to reduce, we would not necessarily be as critical in serving that entire population, although certainly very few community members have the access for Medicaid members that we do.
Some additional context is that what the CCOs have been facing this year is that the state cut their reimbursement for Medicaid. And the state did that because they evaluated based on a formula that I don't know any of us fully understand, that Lane County residents need less comparatively than residents of other counties. And so they cut the rates going to our CCOs, which then dramatically impacted our CCO's bottom line. And that makes it really difficult to negotiate because the CCOs have seen such a dramatic decrease in revenue. And when you look at revenue compared to expenses, they have been more dramatically impacted by that loss of revenue than they have around increased expenses for patients in the community. That said, we also have data that the state sent us around total cost of care. So that is everything, the whole universe of expenses for a given patient, whether it be in the ER or the hospital or primary care or specialty care or pharmacy. All of that goes into the calculation called a total cost of care. And the goal in having a primary care medical home, which is what we are as a federally qualified health center, is to decrease the total cost of care. So you provide a really robust primary care, which is a more expensive kind of primary care to provide, in order to decrease the total cost of care. We have demonstrated success in this. So we are one of the only practices in the state that has actually decreased costs year over year, total cost of care for our population. However, when the CCOs look at us, they say, you are a very expensive primary care provider. And so what we're having to do is go back and forth and say, well, pull the data in a different way. Let's take a look at total cost of care, because you should be investing in primary care if that's resulting in total savings for you. So those are the sorts of conversations that we're having, because it is hard on its face for the CCOs to say, oh yeah, we should pay you more. They pay us a lot compared to other primary care providers.
So you can pay me now or you can pay me later conundrum.
Or pay someone else later,
pay someone
the
else later.
hospital later.
Yeah.
You know?
So what you're saying is healthcare is a system. Some parts aren't working as well as others, and it's affecting all the parts.
Yeah.
Got it. Thank you.
Yes, so going back to that, our goals will be, and we have done our own internal calculations in terms of our increased costs, the population that we're serving, our payer mix, and we have determined what the increase within our contract negotiations we are looking for to help sustain ongoing operations for both CCOs independently as well as the state. And we do have the opportunity to request that the state reevaluates that PMPM because we have had a vast change in our service delivery model. So both West 11th and South Lane operate very differently than our Eugene Springfield-based brick and mortar clinics. A rapid access clinic means that you are not sustaining a panel, so you are not actually getting the PMPM for the patients that we are seeing in West per member per month. That's the capitation payment. We're not receiving that. We are using that location as not only access to emergent care, but also as a pipeline for new patients to be able to be seen as a new patient more quickly. They will then be provided a medical home, which will be one of our other clinics that sustain patient panels. So it is generating an opportunity for revenue in some of our other clinical spaces, but a very different service model for an entire clinical location.
Quick question. You said Cottage Grove was like that as well? There's no patient panels there?
No, West 11th is no patient panels. Cottage Grove is different because it is a rural health clinic.
Okay, but it does have patient panels?
It absolutely
Okay, I
does.
wanted to make sure that.
But we are also serving members of out-of-county CCOs because of our close proximity to Douglas County, and we cannot carry panels with those CCOs because we do not reside in that county. We are a participating provider. We can serve their members, but we cannot create the same model for our Douglas County patients that we do for our Lane County patients. So we have the opportunity to go back and say we are doing things differently. That changes cost, that changes how you're paid. We need to have you reevaluate this rate. And so we are actively working on that as well. The other impacts, obviously some of the challenges, you're all very aware of federal impacts, both around Medicaid eligibility executive orders that are dictating some of the way that we provide care and the care that we can provide. 340B, which is a discount prescription program that we can connect our patients to, where they get prescriptions at a lower cost to them, and we share some of the profit for facilitating that prescription. And so there is a revenue opportunity there. And it is a program that federal leadership has looked at several times over the course of different administrations, and is always kind of under scrutiny. It tends to be very lucrative in the hospital system, and that is what kind of raises the flag with our federal leadership. It is not to the same degree at the FQHC or clinical level, but the worry is that we will get kind of sucked up into the overall assessment that would include those larger systems using the program.
And really quickly here, our intelligence federally right now, we did get the draft H&HS federal budget that was submitted to OMB, which I don't even know what that stands for.
Office of Management
Budget.
Office of Management and Budget. Thanks, everybody, for helping me out.
You're the only one that didn't know.
I clearly am. You learn something new every day. So that draft budget, though it includes some massive draconian recommendations for cuts to a lot of programs that would impact us in Health and Human Services, it does contain base grants for CHC clinics, and it does include funding for a 340B program. So that is optimistic that that the current administration is proposing a budget that includes CHCs and 340B in terms of our sustainability for the coming years. So I just wanted to let you know that's our current intelligence, and this is just very early. Just anyone from the public who's watching, this draft budget will ultimately go into the president's budget, which will get completely reworked in Congress. So it's just an early indicator. It's not a budget that's on the table for a vote.
Right.
Go ahead.
And when you say there's funding for CCOs and 340B program in it, for CHCs, excuse me, we don't know what level, just that they're in there?
It has a top line number, but it doesn't, I didn't see the year-over-year comparison.
Whether it's an increase, decrease, or flat, okay. And as you said, lots more negotiation on that to happen before
Yes.
it's anything real. Thank
And
you.
there are plenty of lines that are zeroed out.
Uh-huh.
So it was optimistic that that was not a line that was zeroed out.
Got it.
Some of our other opportunities are to increase the number of commercial contracts
Yes.
that we agree to. This is in anticipation for potential reductions in members of our community that are eligible for Medicaid and may need to find commercial options. This is also in response to the population that we are interacting with in our South Lane clinic in terms of the type of coverage there. They had another major medical group system that left that area, and a lot of those patients are looking for a new primary care home, and they do have commercial insurance, and so we are really evaluating how to be responsive to that group, as well as open up some opportunities for, unforeseen impacts to the population's coverage. And then one of the areas that we had anticipated rolling out this fiscal year, given our current status, we're really kind of focusing in on those primary care services while we are getting ourselves back to that break-even point. So we will see a delay, but at some point we will be planning to implement full-scale dental in our South Lane clinic location. In the meantime, while we are not actively providing services in that space, we have reached out to our community partners in South Lane to see if there's a way to have that space utilized for the benefit of the public, while we are unable to do that in this coming fiscal year. Yes, Commissioner Buck.
How much time lag are you anticipating before we can open that dental down there?
The plan is that as we find our sustainability again in the coming fiscal year, that we will evaluate adding those expenses back into the budget plan for FY27.
So a year delay.
Hopefully. Yep, we need to see our financial trajectory moving the other direction pretty significantly before I think it would be wise for us to continue on a pathway of investing in new service lines, because all of these new service lines will operate at a deficit until you can build them up. And I think we've gotten to a point now where the risk of us pushing forward on that work until we see a change to our financials, that risk is, in my estimation, too great a risk for the county to bear.
So did I hear correctly, Lisa, say that space that you have available for a dental clinic, we're looking at maybe renting that to some outside dentist? Is that what I heard?
That
Okay.
is one option.
Okay, I just
We're
wanna make
also
sure
working with LCC to see if that they have educational opportunities that could be offered in that space and could result in a reduction in the rent that we pay for that location. So absolutely thinking outside of the box on a way to kind of defray some of that cost while also benefiting the community.
So if you rented that to a dentist, that wouldn't necessarily take the patient base that we want to serve in dentistry and put that on that provider,
Not
right?
necessarily,
Okay, right. Go ahead, Commissioner Buck, thanks.
While I understand completely the reasons for the delay, I just want to put out there that that was part of the pitch of opening the clinic down there. And I think the community expects that at some point. So
Absolutely.
I don't want it to be transformed into another space where we can't immediately turn back and then start the dental program that we intended.
Yes. As part of the build, we have invested and already have, ties to providing that service. We have equipment. We are prepared to do that as soon as we have built up enough of a reserve to invest in that initial period where you are paying a dental director to build your program and you are paying for the onboarding of your staff while you are not actively serving the volume of patients that you need to sustain the program.
Great. I just don't want to get into a long-term lease with somebody.
Oh, not at all, no.
If we can't turn it
Yeah,
back on.
we've been clear that it is this coming fiscal year that we are talking about that space being available and no commitments beyond that time that it would be available.
Thank you.
Okay, so some of the other changes that we've made to reduce costs around, our budget, as we're building our budget, how do we reduce costs? Some of those ways is to really look at, like I said, really focusing in on those core primary care services. So there are a handful of services that we provide that our federal funder, HRSA, states as additional services. They are not part of core primary care. And therefore, those are areas where we have an opportunity to pull back and say we are still meeting all of the requirements of our federal funder. We're going to either pause or discontinue these kind of ancillary services while we focus in and make sure that we are still serving the primary care needs of our population. And so there were discussions both with our health council as well as our leadership around those options. Those options were integrated behavioral health and our alternative medicine, which includes pain management, the allergy, as well as acupuncture. And so those are the areas that HRSA would permit that we would make reductions without any impacts to our eligibility as a federally qualified health center. We also demonstrated a large decrease in our personnel budget through the elimination. Yes.
But of those four, we only chose to eliminate pain management and acupuncture.
Absolutely.
Yes, we kept integrated behavioral health and allergy.
Yes,
Just wanted to make
we
sure that's
all
clear.
recognize that integrated behavioral health is, again, a highly unmet need in the community. We felt that it would be detrimental to reduce or eliminate those services. We did a really thorough look at where some of those other specialized services were available in the community before we considered discontinuing to provide them internally. We did find that access to an allergist was incredibly limited. That is why we're retaining that service. It would be very challenging to find the patients that we serve today an alternate if we did not do that. In terms of acupuncture work, there are a number of providers, up to 30 providers in our community today that provide that service, some of which do accept sliding fee discounts on their services similar to ours. So there would be an opportunity for some of our patients that qualify due to income to receive those services at a discount, as well as pain management. A number of the providers that we use also have private practice. So we're going to help support them in setting up contracts with the payers that we work with so that they have the opportunity to actually care for those patients in their own private practice in terms of continuity of care. They would stay with the same provider. And so we've offered to help them at the table and use aggregate data from the services they've provided for us over the years to demonstrate their value to the system as part of working with those payers. As mentioned, we saw a decrease in FTE. Those were all vacant positions. We have not displaced any employees at this time for a total of 53 FTE reduction. Really looking at positions that we've held open over the years so that we can rapidly address a shift in staffing levels or a change in the needs. We recognize that has an impact on the budget even while those positions remain vacant. So we can realize savings by going ahead and eliminating those from the budget and just being prepared to evaluate each item as it is needed, and we will review those FTE requests at that time. Again, reduction of locums providers. Locums are temporary providers. They are intended for use while a provider is on extended leave or vacation and you need continued coverage. We have used them in the past to care for patients while we have had provider vacancy. We don't anticipate that being an ongoing challenge. We will absolutely only go back to using a locums in the case of an extended leave that cannot be covered by our existing provider staff, which will be a huge savings. They're actually quite expensive, even compared to our fully loaded providers that are employed by the county. And then, as I mentioned, that focus on primary care. Some of the other things that we have modeled in our financial projections is an increase in new patients. Those new patients start kicking off per member per month payment, so we have benefit in bringing those individuals on. It also creates better penetration of the members assigned to us by the CCO, which is just good healthcare, to be seeing and actively serving patients that the CCOs have assigned to you, because if you're not, nobody is. And so it's really important to us that we get those individuals through our doors and make sure they have the care that they need. In order to get to a sustainable level and recoup where we've seen reductions in revenue this fiscal year, we've committed to serving 100 new patients per week, and this is across all of our clinics. And we were just looking at our reports yesterday, and we can confirm that since January, so since the beginning of this calendar year, we have met that goal. We have either served 400 or plus, 400 plus each month since the beginning of the year. So this is something that we're actively doing now and is part of that financial projection. Okay, I think so.
Just a time check, Lisa, how are we doing on time?
We have 10 minutes to the hour.
No, I mean for you.
Oh, we are pretty much there.
Okay, good deal, thank you.
Zach, do you want to lean into this slide, or would you like me to continue to talk through it? This is just kind of a breakdown of our revenue. So these are some of the sources where we receive our revenue. You can see those listed there, as well as spelled out to answer any of the questions on the acronyms. And so these are kind of our major sources. As you can see looking at this, the federally qualified healthcare grant from HRSA are federal dollars. Our alternative payment care model is our state dollars, which are often passed through federal dollars. Our coordinated care organization capitation are funded through the state dollars, which again include federal pass-through dollars. 340B funding is federal, And then quality performance are those metrics established by our CCOs annually that they feel drive improved healthcare and reduced cost. And so we will see returns on those metrics if we meet the goal that the CCO has put forward for our assigned population. So again, those are CCO dollars that are coming to us. And we just wanted to demonstrate this to show, as you might guess, a federally qualified health center is very much reliant on those federal funding sources, continuing to support the care that we provide. Today, we received $0 from general fund to support the operations of the community health centers, and that has been the case now for decades. And currently, looking at our numbers for FY24, because we're in FY25, we increased the number of residents, so these are unique individuals, by 15% over the prior year. And so we are actively showing that growth, which should translate to increased revenue as those, as we see those billing events successfully billed and reimbursement obtained.
Let's take a chance for some bottom line numbers, which Zach has, and I think it's important to share. So our projected operating deficit for this year, our total, what we assume the fund will be negative because we have a lot of one-time expenses that fell into this year. And then going into next year, what the projections are. And the projections vary widely depending on our performance for next fiscal year. The fact that we are meeting the 100 patient a week goal right now is promising. We really need to continue that performance. But really looking at where we are and what the possibilities are, I think the possibilities are actually strong that we could potentially wipe out this deficit or get pretty darn close next year. You want to talk about it?
Sure. I think looking at a moment in time, it's always tough when talking about FTE and positions because they change very frequently. So we have the proposed budget. I think it's coming next week, if not the week after. So I was looking at sort of the adopted budget for this fiscal year and FTE, and then what we are, the county administrator is proposing for full-time equivalent positions. And that change is about a decline in 13%. So we are seeing those periods of time, knowing that depending on what you're looking at could shift those percentages changes, but with those period of time, a 13% decline in FTE. Now, to reiterate, those were all vacant positions. Now, when we're looking at sort of then overall personnel costs, so the cost of doing business next year is more expensive than it is this year for a variety of reasons. Benefit costs increase, PERS costs increase, health, don't need to go into more of that. We'll talk about to the budget committee. But with that even 13% decline in FTE, personnel costs compared to that same period of time, less than 5% decline. So we're seeing greater increase in personnel costs, which we're aware of. That's still not quite seeing potential that budget savings. So what we have in front of you, just a very high level, the beginning fund balance was where we started this year. So that was our resource, that was our kind of our savings account, checking account going into starting this fiscal year. Then we've broken it down into sort of operating performance of how we're doing in the day-to-day work of the clinics, coming in with the day-to-day expenses, with then assuming the revenue sources that were on that last slide. We then separated out with sort of one-time funding. So in the way that sort of fund accounting works is we got all those donations for great for the South Lake Clinic 2, 3, 4 years ago. Those went into the checking account. We're paying the capital bills now. So it's really then drawing down that one time, increasing those expenses because the revenue was prior years. So we're doing sort of the, not trying to do any tricky accounting, it's just the way that fund accounting works. So with that, sort of projecting overall, having this department ID or this organizational unit finish, estimated at this time, the number changes daily to what that eight number is on your worksheet.
8.4 million,
Yes.
give or take.
So with that, we've talked a little bit about what we're doing going forward. So the success that Lisa mentioned, also Suzanne and the team, of getting the 100 new patients per week. So the way that we are funded, as we talked about capitation and per member per month payments, if we add new members into our panels and new members to the FQHC, we get not only that panel payment from the CCOs, but also an additional payment from the state. So filling the panels, having high panel utilization, adding those new members is a positive to our financials. Where then, we've talked a little bit about contract negotiations with the community care organizations, that is in the mix. And then also so revenue opportunities as we're moving into the next year, while also looking at some expense reductions. So we've talked about phasing out the contract with locums and having the temporary contracted providers, so that we'll see that savings next year. When you transition to a new electronic health record, you still use the old electronic health record. So we're actually kind of still paying for next gen. That will phase out as we move into next year. Fortunately, we prepaid a substantial amount of the Ocean Epic contract with ARPA money. So those bills will start showing up, but we will see some offset from the next gen costs going away. And then it's reducing discretionary M&S where possible, and reducing some, the extra health budget we have to sort of come more in alignment with current operations. So with that, at sort of a high level, do you want to share the good news?
So we are projecting potentially, if we met all of our goals, we would have an $11 million operating surplus next year, which would, of course, be able to completely wipe out the negative fund balance. Now, if we don't meet all of our goals, that will come down to a certain extent. The other thing, though, as a federally qualified health center, we look at our budget holistically. We still do have Lane County Treatment Center, which is at any given year projected to be $4 to $6 million in the positive, and can help us with any deficits that we are not able to recover through the performance next year, and all of it with the big asterisk about federal funding, and that this could be impacted by our payments that we receive.
So I guess it wasn't really clear to me where the $8 million deficit money's coming from.
How it's generated, or?
Well, if you're saying that at the current year projection, we're gonna be $8.4 million in the hole, the public's probably gonna ask, where's that money coming from? How are we gonna meet that for this year? Are we just gonna carry it forward somehow on a large credit card with miles points?
No credit cards.
Large credit card.
We can't do that as the government.
Yeah, joy of fund accounting. So we have a few options. One is we let it go into the deficit for the year. Now, the community health centers operate in Fund 288 in our accounting structure, which is a part of, rolls up to Fund 286 in our accounting structure. Fund 286 has enough in the checking account or the savings account to absorb that. So we're just, if we let it go, we have funding in other places. The Lane Care, which is part of our behavioral health unit, has a substantial fund balance. So on paper, it would basically be that. The Lane Care unrestricted.
This is the old rob Peter to pay Paul thing until you get it working, right? Is that kind of what you're saying in an essence?
I mean,
We just,
Put money in your checking, out of your savings.
Yeah.
exactly,
We all do it.
right, yeah.
we have, go ahead.
Well, it's just like when you go to the bank and you say, I want a mortgage, and they look at the money that you have elsewhere to see, could I recoup that from you if you know, so that's essentially what it is. We're not taking money from these other areas in order to pay the CHC deficit, but we're using it to demonstrate that if everything went wrong, we have the money to pay the bill.
Right,
Good.
that's what we're not paying $8.4 million worth of bills.
Right, that's good. I love it when you speak the 286 numbers. Great, good job.
Yeah, I was trying to avoid the fund accounting conversation for
Go ahead, Chris,
Wednesday
you
morning.
have questions.
Thank you.
So-
I'm mindful of time, but I have a couple of questions, two that relate. One is, how are people finding us? How are these 400 new patients a month finding us, or are we finding them? How does that work? And the potentially related question is this idea of sort of open market, private pay insurance clients being served at our clinics. What are the limitations on that, or what can we do as a board? Is there anything you need from us to look to that potential expanded input for patient panels?
Yes. So those 400 patients are finding us through 3 different methods primarily. One is through CCO referral. So they are a member with Trillium or Pacific Source. They need a primary care provider. Trillium or Pacific Source will look at their provider rosters, find a provider that is accepting new patients, and will direct that patient to us for care as long as we have capacity on our panels. We also use those lists of patients that have been assigned to us by the CCO that we do not see have access to care with us, and we do outreach to those individuals and invite them to come in and receive care and be scheduled for a new patient appointment at that time. The third method is word of mouth. Our patients will actively suggest to their friends and family and coworkers, especially those that have some level of Medicaid coverage that are likely challenged to find care elsewhere in the community. And then they will reach out to us and seek care. And then we will work with them to make sure that their CCO has identified us as their primary care provider.
Great, thank you. If I could, my other question,
Question too.
is there a concern about a point of diminishing returns with eliminating vacant positions and trying to increase our patient panels and our ability to serve people? Where is that? That's a lot of positions to go unfilled and to just take off the.
Yeah, and
portfolio.
certainly provider positions, those individuals providing direct care to patients did not make up the highest percentage of those eliminated positions. There are a myriad of positions within our health clinics, both some of which directly impact our ability to build capacity or care for our existing population, and then those that support those individuals. And by eliminating some of those positions, we may increase the workload on our providers around some of that supportive work that is done. But we are definitely not showing any reduction in our capacity. And if we find that we've reached capacity, we are showing that positive trend in our revenue. That's when we get the opportunity to go back and start thinking about where there are growth opportunities.
Great.
And I'd add one part to that too, Commissioner Sugar, that when we originally came to you for the positions for South Lane and for West 11th, we broadened what we needed. We asked for medical assistants, we asked for RNs, we asked for LPNs, because we didn't know who we would be able to recruit. So we filled into West 11th's slots to support the team and then had extras left over. So it isn't so much that we reduced the capacity, we had expanded our reach to try to fill the slots that we had to support and really from a recruitment standpoint. How can we cast a wide net to get whoever we could get in recruitment? Same thing with provider positions, nurse practitioners, physician assistants, or physicians, a wider net than what we knew we'd have the space for. And so that's where a lot of those reductions came from.
Great.
It's a systems piece for us.
Yeah.
So if we could have one position and say, I have 3 different classifications that I could hire for this one position, then we wouldn't have to open as many positions. However, we have to assign a budget to each position number, and because each of the classifications has a different budget associated with it, for one provider position, I might have to open a physician associate, a nurse practitioner, and a physician.
Gotcha.
Thank you. That's all really helpful, and it has my gears turning. I might talk with our county council, who also thinks legislatively about some version of something like a MUPTI for new service lines or new clinics. Like, there should be some kind of way to help meet that gap between the outlay of initial expense to create a service before it starts generating. I mean, that's what those are. There needs to be something like that for healthcare. It just does. I don't know if that's a state legislative financial fix or what that is, but great. Thank you very much for the presentation.
Just as a final thought, if I could, we have a really great media team here at Lane County, and I'm often wondering, when you say word of mouth, Lisa, I'm wondering why Neil and his team couldn't produce a great 30-second commercial, and a small investment on the TV airwaves or social media airwaves would be good to make that word of mouth issue give us the goals that we're trying to achieve. At least I think in my mind that would boost it. Just a thought.
That's a great idea. And we have not done that in the last handful of years because we didn't have capacity. We had a lot of provider vacancies, and we didn't want to advertise and then tell them it'll be 6 months before we can see you.
I understand.
We are now in a place where that is a very appropriate suggestion.
Yeah. Commissioner Ford.
And a follow-up on that, I was kind of rejoicing internally that we're looking for patients.
Right.
Because for so long we were,
Yeah.
as you say, putting them on a wait list. So it's a wonderful position to be in.
Great. Commissioner Buck, go ahead.
I just want to make a more general comment. You know, we are in this position because of those opportunities in the last few years. And those were really, really important opportunities to take. We knew that it would have a hit on the budget. And those opportunities, especially as a whole, may not happen again. And the fact that you can work out the budget over a couple of years to get us into a more solid situation is just a testament to the good work that you're doing in the department. So I want to thank you for that, thank all of you for that, and your other staff that have been working on it. And I want to thank you for taking the opportunities at the time when they were presented, knowing that they were really hard decisions to make, because we are now providing more services to the community as a result. And we can work ourselves into a position where you're getting positive cash flow. We don't have any other expansion opportunities other than the dental clinic at South Lane in the near future. And you know, if we get a few years of positive cash flow under our belt, then we can think again about what kind of additional expansion opportunities we could potentially have. We obviously had a huge interest in midwifery services, and that's a real need in the community, but we knew we were not in a position to take that on. There may be something else that comes our way that you see in the community as a huge need in the next coming years. But this is just a transition period, and the county can handle it. And that's what we're here to, and provide a safe, stable place for everybody to see healthcare. So, you know, this was kind of a bad news, good news situation. And it's really good for me to learn the depth and go into it, because this is, it's almost like a budget committee meeting. This could have been for the budget committee, right? Easily. But it went into more depth, and I really appreciate having a separate work session just to really go in depth on a particular division on the budget, because this was really important for us to know about, and also be able to support you in the transition period.
Thank you.
Thank you.
Great. Any other questions for anyone? Yeah, thank you for bringing this forward. You all sound like entrepreneurs, risk and reward and making it work. So I appreciate that about you very much. Thank you for doing what we do in the community and using these dollars that the community gives us to the best ability, and the government as well. If there's no other further business, this concludes our work session. Our next regular session of the County Commissioners will be Wednesday, April 29th at 9 o'clock in Harris Hall. Tuesday, excuse me. Tuesday. I was getting ahead there. Tuesday, 29th at Harris Hall at 9 o'clock. This meeting is adjourned. Thank you.